and welcome to Beyond the Scales, starting the obesity conversation, where we unravel the complexities of obesity. I'm Emily, and I'm joined by my co-host, Fran.
Hi everyone, we're two medical students on a mission to demystify obesity, as there's so much more to it than just a number.
We're joined by Consultant Bariatric Surgeon, Mr Lee Humphreys, who's working with us on this podcast. He brings a wealth of clinical expertise to help us navigate this very complex condition. Hi Lee.
Hi Emily, hi Fran, nice to see you again.
So we thought today it'd be great to talk about bariatric surgery, especially as you perform the surgery, so we thought you'd bring quite a lot of knowledge to the subject. So
good, I hope you're not doing anything for the next 4 hours, because I can talk for a long time about this.
Could we start from the beginning? So what are the guidelines for referral? How would someone get to you?
Okay, good question. So in England, and the guidelines are slightly different in different parts of the UK, nice criteria for referral for bariatric surgery are exactly the same as the nice criteria for entry into a Tier 3 specialist weight management program. And that's deliberate because in England, you can only access bariatric surgery via a Tier 3 specialist weight management program. So patients need to have a BMI of 35 with a weight-related comorbidity or a BMI of greater than 40. And you don't necessarily have to have a comorbidity if your BMI is greater than 40. You can reduce those BMI thresholds by 2.5 for non-Caucasian people. NICE in 2014 said that patients with a BMI of between 30 and 35 with newly diagnosed type 2 diabetes should also be considered for referral for surgery, because that was the first time that we started to acknowledge that bariatric or metabolic surgery in this instance is a very, very effective treatment for type 2 diabetes.
Could you tell us a little bit about the procedure, about what actually happens in the operation?
Okay. So there's not just one. So the two most commonly performed bariatric operations in the UK currently are sleeve gastrectomy and Roux-en-Y gastric bypass. The gastric band, which is probably the procedure that springs to mind when you talk to most people about bariatric surgery, was extremely popular. It has really fallen out of favour worldwide now, although some are still performed. And quite a few are still performed in the private sector. But as I said, sleeve gastrectomy and Roux-en-Y gastric bypass are the two most commonly performed operations now. Sleeve gastrectomy is the most commonly performed bariatric operation in the world. So we'll just talk about some principles really, rather than the sort of complexities of the individual operations. But bariatric surgery is performed as laparoscopic or keyhole surgery. Most patients, certainly in our unit, will stay in hospital for one night and they will go home the following day. Patients are up and about, walking around, within 4 to 6 hours of having their surgery done. It's very safe. There is a national bariatric surgical register that all patients who have surgery on the NHS and privately should have their operations entered into the database. And that database allows us to look at not only how many operations are being performed, but what the complications and the mortality rates are. So we know from that database that the surgery is very safe. And there are some, common misconceptions that it's dangerous and, people stay in hospital for a very long time, but that's not the case. Sleeve gastrectomy involves removing somewhere between 75 and 80% of the stomach. And we basically turn your stomach into a long, narrow, sort of banana-shaped tube rather than a sort of big floppy bag. And that operation doesn't involve touching the bowel or in any way. A Roux-en-Y gastric bypass is a little bit more technically complicated to perform, but it involves making a small pouch out of the upper part of the stomach and then bringing a bit of small bowel up from further downstream and joining that onto the pouch and then rejoining the bowel further down. And that means that, food enters the bowel much further down the digestive tract than it normally would, and we bypass, where the name comes from, the duodenum and the first part of the small bowel. They both have their pros and cons, but they're both very effective operations for weight loss, and they both, importantly, treat type 2 diabetes.
Interesting. And how do you determine which method you would use for each individual?
So that's a very good question. There are several factors. Patient factors, first of all. So we obviously do a thorough assessment of the patient, take the factors of their medical history, whether they've had previous operations. So let's say someone's had multiple operations on their abdomen before. One of the downsides of the gastric bypass is you have to be able to move the small bowel around to do the operation. If you've had multiple abdominal surgeries, there is a risk that you would have adhesions inside your abdomen that mean that we can't safely or easily move the bowel around to perform a bypass. So a bypass may not be an option for a patient in that situation. If patients have large abdominal wall hernias, again, that can make a gastric bypass very difficult to perform. So we may, suggest the patient in that situation has a sleeve gastrectomy. Because with a sleeve we don't have to touch the small bowel, access issues tend to be less of a problem. One of the downsides of sleeve gastrectomy is that it can cause acid reflux in 1 in 5 people who didn't have acid reflux before the operation. So if you have someone who's very symptomatic with acid reflux and they need bariatric surgery, my personal practice would be not to offer them a sleeve gastrectomy because there's a very high risk that it will make their acid reflux work. If they're suitable to have a gastric bypass, then they should have a gastric bypass, because not only is it a great operation for obesity, it's also a pretty good operation for treating acid reflux. So it's a combination of patient-related factors, what medication they may be on, and then procedure-specific factors. Now, most of the time, patients will come with an idea of which operation they would like. And often that's because they've got a family member or a friend that's had an operation, and either they've done really well with that operation, so they want the same operation, or they might not have done so well and they want the opposite operation because they think that operation didn't work. I mean, it's never quite as simple as that. The majority of the time, if a patient comes with a preference for one operation over the other, and we've assessed them, and there's no medical or surgical reason why we think they shouldn't have the procedure that they've come in favouring, we tend to go with that operation. So it's a joint decision between the patient and the surgeon.
And have you found family and friends do have quite a big impact on the patients you're seeing then about
Huge.
what surgeries they want?
Huge. So it's really important for patients who are coming for bariatric surgery that they've got support, certainly from their immediate family, because if they don't have that support and there's sort of undermining behaviours going on at home, and I've seen this several times with patients, then they find it much more difficult to make the lifestyle changes that are necessary and adapt to life after surgery, which is different. So having that support network around you from your family and your close friends is really important for the sort of perioperative phase and really for lifelong, for longer term outcomes.
And in terms of recovery time for the 2 procedures that we're discussing, are they the same or do they vary as well?
Yeah, they're very similar. As I said, an average of 1 night in hospital. Most people, depending on their job, will be back to work within 4 weeks. If you have a very sort of low impact job, we've had people go back to work in a couple of weeks. If you've got a very manual job, you may be off work for 6 weeks. But the recovery time is, in keeping with most other laparoscopic keyhole operations.
How effective are the operations? Is one better than the other? Or it depends on the patient?
Great question, and one that we get asked all the time.
Yeah.
it's not a straightforward answer because, people will get a different response to the same operation between individuals. What I always say to people is that they're both good operations, and if you work with them, they will both offer you the opportunity for durable long-term weight loss, which is what we're looking for. If you don't work with your operation, and by that I mean if you don't follow the lifestyle advice and the other things that we've talked about before, you are far less likely to get a good result. And it is entirely possible to put all of your weight back on after a sleeve gastrectomy or a gastric bypass. So, we talk about them as being a tool. It's not a magic bullet, and you certainly can't just have an operation and then carry on and do whatever you want and expect to keep your weight loss, to keep your weight off in the long term. So it's a lifelong commitment. Now, until fairly recently, the question of which was better was fairly hotly debated. And it is still fairly hotly debated, and it depends who you talk to. But there's lots of data about various bariatric surgery. But there was a randomized controlled trial, big multi-center trial in the UK called Biband Sleeve. Originally, that trial started out as Biband, and it was comparing gastric bypass with gastric band. Sadly, Biband started around the time that gastric banding fell out of favour and sleeve gastrectomy really took off. So the trial was adapted into 3 arms to include sleeve. Now, the headline outcomes from that trial came out in the middle of last year. And what the trial has shown on a very sort of high level is that gastric bypass outperforms sleeve and gastric band for weight loss, for treatment of complication of obesity-related disease, and interestingly, in quality of life outcomes. I think a lot of us thought that sleeve would probably do better than bypass in quality of life, and it hasn't. Sleeve outperforms gastric banding, and so the sort of the takeaways are that sleeve and bypass are significantly better than gastric banding. So I think it's put the argument about gastric banding to bed, really, for most people. And that bypass gives more durable, better weight loss. And also it's looking more and more like bypass gives better, longer-term remission of type 2 diabetes. So it's not to say that sleeve's a bad operation. It's not what we're saying. But we're saying for the first time with high quality evidence that bypass is probably better. So if you're someone who's suitable for either operation and you now come in and ask me which is better, I have got some data now to say I would probably suggest to you, if you're prepared to take the side effects and the potential complications that come with bypass, then a gastric bypass is probably the right operation. But it's not the right operation for everybody. There is no one bariatric operation that is right for everybody.
And do you signpost certain patients towards reading that literature?
That data hasn't formally been published yet. But I think one of our jobs as clinicians is to summarize data like that for patients in a way that they can understand. There will be a few patients who are quite capable of reading a scientific publication and understanding it, but the majority of the public aren't. So we shouldn't just hand them a paper and say, this is why it's best. It's one of the skills you learn as a clinician is to distill the evidence and present it to patients in a way that they can understand. And help them by answering questions. And this is all part of, for surgery, what we call informed consent. Because when I meet patients, and we're talking about an operation, clearly I tell them the advantages of an operation, but I've also got to tell them what could potentially go wrong, what the sort of short-term complications around the time of surgery may be, but also what the long-term implications of having a sleeve or having a gastric bypass may be, so that patients can make an informed decision. If all we say to them, this is a great operation, you lose loads of weight and feel better, sign here, well, that's not informed consent. And if something goes wrong, then patients aren't fully informed. So it's part of what we do when we're counselling patients about surgery.
And I think that leads greatly into my next question of what are the complications during the surgery and potentially afterwards?
Sure. So there are some general complications that can happen with any operation. So infections, bleeding, DVTs, PEs. And when we're doing an operation like a gastric bypass, where we're dividing bits of bowel and joining them together, there's a risk of a leak. Now, in a Roux-en-Y gastric bypass, you have two joins or anastomosis. There's a risk of a leak at either of those. With a sleeve gastrectomy, we're using a stapler to remove 75-80% of the stomach, and there's a risk of bleeding or a leak from the staple line there. So those are sort of the main short-term around surgery complications that we talk to patients about. Of those, from a surgical point of view, a leak is the one you always worry about the most. Then, I talk to patients about longer-term complications, and they're a little bit more procedure-specific. So, for example, with a sleeve gastrectomy, we've talked about the 1 in 5 risk of developing acid reflux. And for most people that develop acid reflux, that can be treated with medication. But actually, for a small but significant number, that reflux is really quite significant. And it doesn't respond to medication. And they can actually require conversion to a gastric bypass to treat the reflux. So that's something we talk about. There's now emerging evidence that probably because of the risk of reflux with sleeve, that in the longer term, patients might develop a condition called Barrett's esophagus, which you may have heard of. Now, Barrett's is where the cells that line the esophagus change from being squamous cells that you normally see in the esophagus to look more like cells from the stomach, because the esophagus is not designed to be exposed to acid. Now, the cells change to protect themselves against acid, but that change has malignant potential. So patients who have Barrett's esophagus are at more risk of developing cancer of the esophagus than patients who don't. So what we've now started doing in our unit is every 5 years after a sleeve gastrectomy, we'll do an endoscopy to have a look down. Now, we do an endoscopy on all our bariatric patients before surgery, whether they're having a sleeve or a gastric bypass, because we believe that's good practice. And it's quite useful for picking up several things. And for example, if we picked up someone who had significant esophagitis prior to wanting a sleeve, they may be symptomatic, because not all patients with reflux have symptoms. And that might be a really good argument for them not having their sleeve gastrectomy. And if you hadn't scoped them before and they wanted a sleeve, the likelihood is they were definitely going to run into trouble afterwards. So with sleeve, we're now talking about reflux, we're talking about Barrett's, and potentially the need for being endoscoped every 5 years or so for the rest of your life. Now, that interval may change as we get more data. We may find that the risk is less than we thought it was, and we'd scope people less. We may find it's higher than we thought it was, we scope people more. But we don't know yet, so we're being pragmatic. With a gastric bypass, there are probably more longer-term risks that I talk to people about. So things like developing diarrhea. Up to a third of people can develop chronic diarrhea. There can be multiple potential causes for that, and sometimes we can't find a cause. Increasingly, we're recognizing that around 30%, maybe slightly more, of patients who have a gastric bypass can develop long-term abdominal pain for reasons that we can't ascertain. So that's an important thing to talk to people about.
When you say long-term, how long is long-term?
Lifelong.
Wow.
Lifelong. Now, it's not, in the patients of mine that have developed it, it hasn't been sort of excruciating, crippling pain, but it's been niggling and it's been enough to cause them annoyance. But interestingly, all of those patients have still told me that having a gastric bypass is the best thing they've ever done, despite living with the pain afterwards. When we move the bowel around to do a bypass, we create spaces inside the belly that aren't supposed to be there. And the risk is that a bit of bowel can slip into one of those and rarely get stuck. And that's a condition called an internal hernia. Now, we close those spaces at the time of surgery, but they can open up over time. And that risk of an internal hernia is probably the highest in the first 2 years after surgery when patients have lost weight fairly rapidly, but it persists with them for the rest of their life. So if you've had a gastric bypass and you start to develop abdominal pain, an internal hernia needs to be considered as a potential problem. So those are risks more specific to bypass that you don't tend to see in the sleeve. For us, patients who have either a sleeve or a bypass need to be treated with lifelong vitamins and minerals, and both patient groups need vitamin B12 injections every 3 months, and that's because particularly with a bypass and B12, we've bypassed the bit of the stomach that makes intrinsic factor. Yeah. So the thinking has always been you can't really absorb B12 orally. It's probably less of a risk with sleeve, but it is still a potential risk. So in our unit, we give sleeve patients B12 injections as well because I think it's safer. But the vitamin and mineral things is really important. And patients are at risk of significant problems from vitamin and mineral deficiencies if they don't take the tablets. And again, that's every day for the rest of their lives. So you can see that, from some of these things, it's not an easy fix, and it is a lifelong commitment to various things. And the operations are life-changing for most people in a good and a positive way. But of course, for some people, if you get a major complication, sadly, like with any surgery, they can be significant adverse lifelong effects. So it's not something that people go into lightly. And I think there is this perception amongst certain aspects of the press and maybe in the public that surgery is a quick fix. We'll just go off and have a gastric bypass and lose a load of weight. Well, that's easy. Well, it isn't easy because it does require lifelong commitment. And as we've already said, if you don't work with it, you'll put all of your weight back on again. So, but overall, they're very safe, very effective procedures that will give patients durable long-term weight loss. And currently, surgery is the only intervention that's evidence-based to give long-term weight loss. And that's really where the health gains are. It's not about the short term, it's about the long term.
And how long are the waiting lists at the minute?
Well, look, it varies around the country, but the honest answer is it's a long journey for these patients because, as we already said at the beginning, you have to come through a tier 3 weight management program. So you'll wait, even once you get a referral to a weight management program, you'll wait to start the program, and that could easily be 1 to 2 years to start the program. Then you'll spend time in the program, which could be anywhere between 6 months and 12 months, in some cases a little bit longer. Then you get referred to see a bariatric surgeon. You'll wait to see us in clinic. Then we'll put you on a waiting list and you'll wait for an operation. So, sadly, currently, if you were being referred now for bariatric surgery on the NHS, it's not inconceivable that you could be waiting 3 to 4 years from the time that you start to the time you get your operation. And that's, it's really poor, but that's the reality of where we are.
And by the time patients get to you, have you found that they could be more disheartened about their weight loss, or do you think that they're more eager to have surgery?
Usually, by the time they come to see us, they're really excited because they've been working towards this for years.
Right, okay.
So there will be some patients who are very anxious, of course, because they worry about the risks of surgery. But the majority of people are excited. They've been, they've dieted, they've done all of those things for large amounts of their lives, then they've waited, they've done the weight management program, etc., etc. So, getting on the waiting list for surgery is a major milestone for them. So, yeah, it's usually a nice clinic because people are pleased to be there.
And on the other side as well, are most patients happy after the surgery, or what is kind of the data showing?
Yeah, so look, as I said, for the majority of people, they're delighted with the outcome. And I think what's really nice about this type of surgery is you start to see the results very quickly. And so normally we'll see a patient at 6 weeks post-op as their sort of first face-to-face follow-up. They'll have been followed up by the team on the telephone earlier than that. But usually, even at 6 weeks, patients will be saying, I feel completely different. I've lost X amount of weight. I've got more energy. This is better, that's better. I'm feeling great for the first time in a long time. So, it's quite gratifying that you get the results quickly. And one of the things we haven't touched on is the effect on type 2 diabetes. So we've said that they're currently the most effective treatment of type 2 diabetes. It took a long time for the endocrinologist to accept that lowly surgeons can put diabetes into remission, but we can. And what's fascinating about it is that you can come into hospital a type 2 diabetic on medication, you have surgery, you go home the next day off all of your diabetic medication with blood sugars in the normal range. And that's incredibly powerful. Now, how long that effect persists for depends a little bit on how long you had diabetes for before, how much medication you were on, whether you were on insulin, and to a degree, the type of operation you've had. And some patients will get what we call a complete remission. And by that, I mean sugars in the normal range without any medication. Some patients will get a partial remission, which means that they still need diabetic medication, but less than they needed before. Some patients will get long-term complete remission. Other patients, it might be less. But even in the patients who only get complete remission for a shortish period of time, the actual benefits on their health and the reduction in the risk of cardiovascular events later in life is there. So I think for me, in the type 2 diabetics, that's the group where I really think that we very clearly make a big difference. And that's quite gratifying. But like with any type of surgery, some patients won't get the result they hoped for, or we hoped for. Some patients sadly will have a complication of surgery. Some patients might get a serious complication like a leak, which can be really major problem for them. They spend a long time in hospital, and can be devastating for some patients. So there is no surgery where everybody does well without a complication, but far more patients do well without significant complications than patients who don't necessarily get the result they want, or patients who get a major complication. I think the number of patients that get major complications is very small compared to certainly where it was 20 years ago.
In terms of, for particularly medical students listening that maybe haven't gone on placement yet or haven't seen bariatric surgery yet, how do you test or see if there is a leak?
So at the time of surgery, we will do a leak test. Now, that usually involves putting some normal saline mixed with a blue dye down a big tube called a bougie that goes either inside the sleeve or inside the gastric bypass. And you put that in under pressure and you look for a leak. Yeah. Now, that leak test does have some downsides. So that will show you if you've got an immediate problem. And if you've got an immediate problem with one of your joints, then there's usually a technical issue. So, your stitches may have been slightly too far apart if you're doing a bypass, or there's been a bit of a problem with the way one of the staples has formed or something like that. But most leaks are not an immediate technical problem like that. Most leaks are probably ischemic in nature, so they don't usually present for a few days. So most patients who have a leak have gone home well, and then a few days later have become unwell. And they often have quite significant abdominal pain, or they get a high fever, or there's lots of them, but they're not right. And they know they're not right, and then they'll represent to hospital. So just because you have a negative leak test on the table, and it's incredibly unusual to have a positive leak test on the table, although you can sleep well that night, it doesn't mean that your patient's out of the woods and they're not going to leak. But the majority of leaks will happen within the first 5 to 7 days, rarely up to 2 weeks, but the vast majority happen in that first week.
Okay. And I'm guessing as part of the process of getting prepared for surgery, you inform patients about those signs and symptoms and what to look for in case they are in that group.
Yeah, absolutely. And so when we discharge our patients home, they get a follow-up phone call the day after they've gone home. Unless it's on a Friday, then it'll be a Monday. And they get weekly contact from members of our team just to check that they're doing all right. And obviously they're informed of things that they need to be concerned about. They're given a phone number to the direct line to the bariatric team and their answer phone. And so, it's fairly easy to get hold of us Monday to Friday in working hours. Clearly, if it's out of hours, they present as an emergency like everyone else does. But yes, it's about educating patients and giving them a way of getting in contact with you if they've got a problem. Because like all of these things, if there is a problem, the sooner we know about it, generally the easier it is to deal with and the better the outcome for the patient. But unfortunately, leaks are not common. So the risk of getting a leak in primary, so first time round bariatric surgery, with a sleeve and a bypass is somewhere in the region of 1 to 2% with either of those operations. So it's a major complication, but it's not very common.
Right, well, thank you very much for talking to us about bariatric surgery.
I think that gives a very rounded and a really good introduction, doesn't it? Particularly most students that haven't experienced bariatric surgery or gone into it yet.
Yeah, I think that there are lots of myths around it, and I think the take-home message from this is it's safe. We haven't touched on cost, but it's cost-effective. It's mostly well tolerated, and it gives most patients a really good outcome. And that's the reality. There are still lots of people out there who think that it's really dangerous surgery, it's risky, it's done through a very big cut in the tummy, patients are in hospital for weeks, and you can't eat anything ever again. So there are still lots and lots of misconceptions about there. So, for the medical students out there, the take-home message is it's safe and it's nowhere near as bad as some people would have you believe. And so if you're interested in it, find out a bit more about it.
Yeah, great. Well, thank you everyone for listening, and watch out for the next podcast. Bye.
Bye.